Good morning, everyone. First of all, thank you for the organizers for a kind invitation. Today, I'm going to talk to you about 3D printing and application of 3D printing in treating debilitating musculoskeletal diseases. My name is Dr. Deepak Kalaskar, and I'm based at Rowan National Orthopedic Hospital and also an associate professor at Division of Surgery and Interventional Science at UCL. Most of my research is focused on bespoke medical devices and implants with a patient-centered approach where co-creation is a heart of most of the work we do, where we have a close engagement with patients, clinicians, my team, and also we have a close engagement with industry to materialize our goals. To give few examples, we are working with four major hospitals in London, which includes the Royal National Orthopedic Hospital, where we are working mainly on treating different types of spinal conditions, including neck support, looking at which is a class 1 device, class 2 device such as surgical instrumentations and spinal cages, which is a class 3 device. With the Royal Free Hospital and Eastman Dental Institute, we are working on mainly facial reconstruction and bone reconstruction. Again, here we use bespoke technology combined with 3D printing. At University College London Hospital, UCLH, we are working on tendon and ligament graft development and testing, where also we got an ongoing work going in the direction of bioprinting applications, where we are looking into developing different types of materials for use along with cells, mainly into ATMPs. So the example which I wanted to talk to you today is about the biomimetic and personalized 3D printed cervical collar for transverse myelitis. And this work is actually done in collaboration with Royal National Orthopedic Hospital in London. In 2017 and 18, a clinical case was presented to us, a 55-year female suffering for transverse myelitis, who was diagnosed in 2011. So there was a big gap while she was diagnosed until she actually received different types of treatment, which essentially failed. Now, what is transverse myelitis? It is an acute inflammation of spinal cord. The actual reason for its existence is currently unknown. So there is etiologies such as infection or autoimmune. In her case, the actual cause was unknown. However, because of the condition, it resulted into a head dropped, which was because of the severe weakness in her neck muscles. Her arms were paralyzed. She was on a 24-hour care. Her cervical spine levels were also being severely affected, as you can see from a figure here. So this is a patient when in the standing position with the hands actually always in a crutches. At the same time, you can see the neck and the anatomy of the neck. And currently, there were no solutions to help manage her condition. And this is when the collaboration between us and RNOH actually started. So they suggested that she could not tolerate any commercial collars which were currently available because of a very unique anatomical features as a result of the disease. But at the same time, some commercial collars which has been given to her by a clinical team, she was very uncompliant because of the pain and other reasons. The other factor which was very important is the patient lived 4 hours away from the patient from the hospital. That means seeing this patient was not very convenient, or it was difficult to see the patient often. So there was a delay in terms of and when and where the patient is actually going to come, and how often the clinical team are actually going to get a feedback in terms of her disease progression or follow-up. So because she was spending such a huge amount of time during traveling, there was essentially a very limited amount of time she could actually spend with the clinical team in which she can actually interact or being in a compliant position. So these were some of the challenges which actually came out through the discussions during a clinical team. So the aims which we actually were supposed to work with a clinical team were how do we reduce the patient number of visits, whereby we are able to manage our condition. Second, how do you increase the patient confidence and compliance? One of the way we could actually do this is by having a co-creation of that collar with patients and a close involvement of a clinical team. And that is exactly what our approach is, and that's what we did. However, in order to reduce the number of visits, it was important that we can capture her anatomical detail in a correct format and as accurately as possible. So this is where we use the technologies such as 3D scanning, and our choice was here using an RTQA, which is a very well-known scanner in the business. And we use Stratasys Fortis 380 machine for printing these colors, which is a 3D printing. So 3D scanning and 3D printing became the chosen technology to address this question or to address this patient-derived problem. Once we worked on a 3D scan, this is how the scan of the patient looked like. And we looked into the accuracy and the reproducibility of these scans. And when we were completely confident about the quality of the scans and the measurement which we were getting, we don't have to see the patient again because the measurements were captured. So we could do number of iteration on those scans and then provide it to a clinical team or even remotely to the patient to look and visualize them. During that process, then we modified our workflows eventually. So this becomes our initial input, which is a 3D scan of a patient. And then we did different types of CAD modeling and finite element analysis to come up with a most optimum design, which can be given to a patient. We then use 3D printing or additive manufacturing process to manufacture them. These were padded quite well by using current orthotic padding before these collars were delivered to a patient. So this was our first collar, which was given to a patient. She was very happy when we actually given it to her in terms of her comfort level because she hasn't used anything. She was using zero collar when we actually had a first contact with her, and which was concerning for the clinical team. And this is where MIs, who is actually our resident consultant physiotherapist and who's looking after the patient. In order to get a quantitative evaluation of her performance and her usage, we gave patient a questionnaire. And this questionnaire was literally hourly basis. So hourly utilization, 1 hour, 2 hour, 3 hour, and 4 hour. And she has to simply document the pain areas and a level of pain based on her judgment. And that is what helped us to evaluate the performance of these scholars and slowly work with her to develop confidence into a process of co-creation and improve the compliance. After the first color, we have to do number of iterations. And some of these iterations involved using finite element analysis, whereby we actually managed to find out the areas where there is a huge amount of stress and how to manage that stress. By at the same time, taking into consideration what the patient's immediate requirement would be. Now, this patient was very particular. She was very keen on the design aspect of it. She was very keen on how it look, what the color is before she is going to accept and wear it. So we had to take this, and this is what the part and the sort of the joy of co-creation was, that it was not just an engineer coming with a design or a clinician coming with a design. It has to comply and also satisfy patient needs and patient expectation. And what we did in the next stage is we actually has to go through a number of stages of iterations and modify our design based on patient feedback over a period of time. We've gone through about 4 different prototype stages, which include different types of material being tested, at the same time different types of padding and fitting arrangements. So this is how the patient actually look without a collar. When we fitted the collar, you can see there was a remarkable improvement in her posture. This is a close-up where you can see the cervical spine actually quite curved. And when we actually put, this is actually surprisingly quite straightened up, which actually help patient to look straight. At the same time, do some of the simple activities such as, she did not have a difficulty then breathing, because you can see in this position, she always complained in terms of breathing, talking, or even looking at the people when they are actually watching television. So simple things actually improved massively, and that actually improved the compliance. We also seen that she was using this prototype continuously over a period of 4 hours, which was a massive increment, knowing that this patient actually did not had anything for more than 5 to 6 years to wear. And also we've seen a clinical improvement. So this is how our final prototype, which actually given to a patient, look like. It was printed in ASA, which is one of the polymer produced by Stratasys. So as a conclusion, what we did is we actually managed to co-create um, a design in collaboration with our team at UCL, RNOH, and in industry. Obviously, the whole focus was on the patient requirement. Uh, this particular prototype and the design has recently been shortlisted for a prestigious design prize, Weisley Design Prize for the Year Award. And currently, this prototype is on display in London's Design Museum. We also got some the media coverage for the work we have done with this patient, where there is an acceptable interest from various different communities and orthotics. So what next? So recently we have been awarded an EPSRC project based on this work we did to treat multi-neuron disease patients, MND patients, which are widely known. So we are now evolving this particular workflow to create smart collars, which are embedded with different types of sensors to understand how MND disease progresses and how to better manage it. While we are focusing on MND, there are other conditions such as Parkinson's, myelopathies, cervical dystonia, cervical spondylitis, and other conditions too, in both adults as well as in children, which has a huge potential where mismatch of anatomy and custom devices will be more appropriate. I would like to thanks at the end my collaborators, especially Ms. Emma Linsley from RNOH, and a visiting researcher who is also Dr. Luke Hell, who actually worked on this project, and various other funders. And thank you very much. I'm happy to take any questions.